presentation. It is extremely important. This is IOL power calculation simplified. This will be by Dr. Savleen KAUR. Dr. Savleen Kaur is Associate Professor at Advanced Eye Center, PGI Chandigarh. I think this IOL power calculation is one of the most difficult situation where what power to implant and how we calculate and which gives better results.
Good morning and thank you, sir, for that introduction. Because this morning we are talking about kids, and if we want to make our world better, we have to make it better for them first. So having said that, the challenges in IOL power are broadly classified into two aspects. We always have a confusion when to implant an intraocular lens in a child, and then if we decide that we have to implant, what power to implant. The decision of when to implant is largely based on the biometry and the age of the child, and the power would be based on the axial length keratometry measurements and what is the target refraction that you aim at. So I'm going to be talking about these 5 aspects and try to simplify it. The first question being when to implant an intraocular lens. The infant aphakia treatment study that has been, I think, recapitulated by Dr. Parul said that axial length more than 17 and a corneal diameter more than 9 with an age more than 6 months is your cutoff for intraocular lens implantation. But the other randomized controlled trials, and I particularly quote this one from the survey of ophthalmology, which describes all infantile cataract RCTs, and you look at all the RCTs and you see the numbers are the same as the IATS, but once you look at the visual axis obscuration, that is way higher with the IATS as compared to the other studies. So by and large, overall, the risk of visual axis opacification is more with IOLs, but the difference is less depending on what study we are kind of quoting and where we are from. So it's not that black and white a situation, you implant or not implant. And the consensus overall is for a child with a unilateral cataract, you have to go in for a contact lens or an intraocular lens. It's a better option vis-a-vis a child who's having a bilateral cataract. In the Indian context, we have studies by Dr. Jagat Ram where IOLs have been implanted in kids as low as 6 weeks of age, and a particular group of LV Prasad. And we have found that IOL implantation is possible in a select few cases who are less than 6 months, depending on how the compliance with the contact lens will be. So another viewpoint, I think it's a wonderful thought by Dr. Jaspreet, that if you have an age less than 6 months, look at the back diameter. And this is a paper that we published recently, that the back diameter might be a good indicator, even if you have an axial length and a keratometry reading that is not normal for that age or normal for that age, but the age is less than 6 months. Look at the back diameter if you can with the ultrasound biomicroscopy, and if the back diameter is more than 8 mm, you can go ahead and implant an IOL. Having said that, and once you've decided that you have to implant an IOL, we need to know what power to implant. The first aspect is the axial length, the most important. Now, the office measurement of axial length is very difficult in young children and adults and infants, and under anesthesia, you might be able to get a fairly good reading because you might have an eye which is straight. The errors in measurement will produce a greater error in the IOL power calculation, so you have the options of applanation and immersion. Immersion being giving us a slightly higher and correct, more accurate values if you have access to. In the office, the child is often crying and is up-rolling, so the readings might not be very accurate. And under anesthesia, you can ensure that the eye is stable and is straight. And you can take a good reading with a contact scan also, making sure that you don't indent the cornea. Now, you have to take multiple readings because the corneal compression is more likely because they're low scleral rigidity. And you should always have an instrument which has an oscilloscope screen if you can hear the sound of the video. These are spikes that you're getting, and you have to look at these spikes, whether they are coming from the lens, so that you know that you are looking at the correct axial length from the center of the eye. As far as keratometry readings are concerned, inaccuracies will produce errors up to 1 diameter in the IOL power. And for cooperative children, optical biometry is the best because that will give you the most accurate K reading, but it is not a viable option when you're dealing with infants. So you can use a handheld keratometer often when the child is sleeping, or in this case, you see the child is breastfeeding and we are taking a keratometry reading. In the OR, it's again an more accurate method, ensuring that the eye is stable and central. And you have to ensure centration, which you cannot in GA, but you take 2 to 3 readings, look at the standard deviation, it should not be very high, and all measurements should be within 1 diopter of each other. Most people like to take it as the first reading, even before you check an intraocular pressure, and take it without a speculum, make sure the cornea is not dry to get an accurate reading. Now, again, which formula to use? You have an exit length, you have a keratometry reading, and you want to know which formula that you want to use. We are not using the regression formulas very often now, and again, we try to review what is the best formula that we use. People say use Hoffer Q. There's a group of people thought that, okay, it's a small eye, use a Hoffer Q, but it's not true. It's not small for that age. The child may have a normal exit length for their age. So there's no consensus because we're using all adult formulas, but the IATS has used Holiday 2 and SRK-T. These are the two most commonly and the most, will give you the minimum error. Barrett Universal is also one formula that is giving us fairly accurate results, but no randomized trials in children using that formula. So you have the exit length and keratometry. You can choose and play around with the formulas that you have and look at the target refraction and then decide what power that you want to implant. The target refraction, we have said that, but we don't know what target refraction to aim at. You need to have an IOL power which is a balance of what the refractive error will be immediate post-op, and then it has to be no amblyopia in adulthood as well. So as the age progresses in a normal eye, an exit length increase causing a myopic shift is counteracted by the lens flattening and the flattening of the cornea. Now once you do a cataract surgery, you don't have this lens flattening component, and you also have done a cataract surgery, so you have induced some amount of astigmatism. So the exit length is not counteracted by further lens or corneal flattening. So it produces a myopia. Anticipating this myopia, you have to undercorrect the child, and how much to undercorrect the decision is based on the growth pattern. If you have a very small child, you expect a larger myopic shift. But if you aim for a very high hyperopia, you will get an immediate high hyperopic error, which will cause amblyopia. A very small hyperopic error will produce a myopic shift later. So the error should be small enough that you can correct it with the contact lenses and counteract the myopic shift later on also, so moderate hyperopia. Again, Dahans gave us some guidelines. If you use them, you will get a very high hyperopia of +6 or +8, especially when you're operating with infants. So it moved on to the Inyadi rule of 7, and we are following somewhat what Crouch et al. Gave, that a +4 refractive error in a child of age 1 and so on, to give us a sum of +4 or 5. We did a study again, IOL implantation in infants, where we used target of +4 in infants, and the myopic shift was over a period of 3 years was less than 1 diopter. The IATS used 8 diopter undercorrection for infants and 6 diopter for more than 6 weeks. So this is the age group. Still, there is no consensus, but by and large, bilateral cataracts +6 to +8. For a unilateral, you want to keep a little lower. So you have to consider the age at the time of cataract surgery. You have to know what the fellow eye is. If there's dense amblyopia and you have a unilateral cataract, a high hyperopia might not be a very good option. You have to look at the compliance of the parents for follow-up, for contact lenses, and in this era, we have a lot of parents with myopia, so we are expecting a more myopic shift. So the major challenge would be to the post-op refractive error, and it will largely depend on the IOL power that you choose and the target refraction that you keep. There are inherent difficulties, and it is crucial to obtain an accurate IOL power. You'll still get errors even if you use the most sophisticated instruments with you. You will always get one error, but try to make it a very small and a positive one. Thank you so much, Dr. Jagatram. We have been having this IC for the last 4 years now in a row. Thank you, Dr. Jaspreet, my mentor, and thank you, AIOS, for inviting us.
Thank you, Dr. Savleen, for excellent discussion on IOL power calculation. Any question from the audience? Otherwise, what IOL power in day-to-day life, IOL power calculation you use?
Sir, we are aiming at a moderate hyperopia, so depending on the age and the laterality. I think these are the two most important factors. So if you have a bilateral cataract, you aim for a +4 or 5 in a child who is an infant. More than 1 year, you kind of follow the rule of 5. So you have a +2 at an age of 2 years. You have an IOL power, so on, a +1, say at age of 4 years. Earlier, we used to feel emmetropization occurs at 7 to 8, so that's why +8 and 7 used to be the target. Now we are kind of aiming emetropia when the child is 4 to 5 years of age.
Yeah. Otherwise, when we started IOL implantation in children, we used SRK2 formula initially. And then later on, we switched over to SRK-T. And then looking at the studies from Dr. M.E. Wilson, he said that whether it is SRK2, SRK-T, holiday or other, there is no much significant difference in the outcome. That is in one of the study. But most of the time at present we use SRK-T
Yes, sir.
and
Holiday. Absolutely, sir. Whichever formula we use, we will always get an error. We have to try to minimize the error that we get.
So yeah, that's right. Basically, in older children, you can just juggle around with the formula. You're doing an IOL master. The problem comes when the younger children, when you have to do a manual A scan, that is the time the issue comes up with calculation of the IOL power, because they are not fixating and you don't know where the axial length is going. So what the best, what I try to do now is do the biometry, hold the probe and see it under the microscope, because the indentation is the part which is going to create the problem. So you have, when you see your probe under the microscope when you're doing the axial length, probably you can be more accurate that time with getting a, you can say, a closer axial length to the actual. The other thing is when you have those readings on the biometry, because of the issue of compression, you get 5 or 6 readings. So you take the reading with the maximum ACD, that's the anterior chamber depth. That's most important, not the average what comes down. So with that, you can basically get closer to a better IOL calculation using whichever formula you want to use, SRK2 or T, which have been there for quite a long time.
One thing for unilateral cataracts, the residual hyperopia, do you use something different when compared to a bilateral cataract?
Sir, for unilateral cataract, I don't aim a +7 or +8, because immediately that child might not wear glasses. I might not be able to give them a contact lens. So +4, and my threshold is little lower for a unilateral cataract.
Just to reiterate, the prediction error of IOL power calculation will be maximum in children less than 2 years, or axial length less than 22, or keratometry more than 43.5. So we should always remember that in children less than having these criteria, there will always be a prediction error. Now we have to see which IOL formula will give the least prediction error. So we can use Dahan's, or we can use do a simple IOL master 700 biometry, and we can do 20% reduction in children less than 2 years of age, or 10 to 15% as was suggested by Prost up till 4 years of age, and 4 to 8 years of age we can do a 10% reduction. So that will give a fairly hypermetropic result, which will offset the myopia which will happen in the later years.
yeah, very right. Because initially when these formulas were not much there in 1997, Dahan's estimate came. With that it was almost a 20% reduction less than 2 year, and 10% from 2 year to 8 year. But later on we realized that it goes more into the myopic shift. So we adjusted that, and we reduced partly so that we may not get more hypermetropia, or we may not get more myopia ultimately over a period of time. Thank you,
we
Dr.
have-
Savleen.
so we have another
Yeah,
question.
yeah. Ten years.
For 10-year-old, again, I would not keep the child, I will not aim at a very hyperopic error. They are already emetropic. Emetropia, and if I have to choose, like a little, like a 0.5 or something plus.
Yes.
Otherwise,
Yes.
emetropic after, say, 8 years of age.
After 8 years.
I think,
Sir,
yeah.
what about, like, going on to that question, what about if you have a unilateral cataract at 10 years and the other eye is -6 from an ROP? Then what do you do?
So, yeah. So,
other eye no.
So unilateral cataract, again, we are talking about scenarios which are non-complicated. You know, we are not talking about PHPVs and ROPs and, you know, blue ophthalmic eyes. We are talking about, you have to take that into consideration, the existing comorbidities. So if you have myopia in the parents, you have myopia in the other eye, you am anticipating a bigger myopic shift. And a unilateral cataract, again, with the component of amblyopia, you can, I mean, I would keep a little plus, but I mean, not, because it's not going to grow much. The -4 to my mind will not be that amblyopogenic, the anisometropia. So yes, near work, again, you know, there are studies of EDOF lenses, and Dr. Jagatram has a paper on multifocal IOLs in children more than 8 years of age. So again, very select few cases, no comorbidities, the perfect surgical technique, perfect rexes that you have. Sir has implanted even multifocal IOLs. I have done personally a few EDOFs. I think they do well.
Yeah, okay.
So, but then a personal choice if you
Dr.
want to go
Jasprit
ahead.
ke
But
baad?
I like to
Okay.
tell the child that child is, I'm going to lose accommodation. For unilateral, the child is
Okay.
using the other eye, so I'm not that bothered with the accommodation.
Okay, Dr. Savleen, thank you
you.
so much. I think for 10-year-old child, what I do, I keep almost, if it is a E-metrop other eye, I try to keep it just E-metrop or so. Why? Because from 10 year to till 18 year child will be some little growth in the axial length take place that will make 0.5 to 0.75 myopic this child. But what I do, I keep emetropia at 10 year, so that it may go a little myopic, 0.5 or 0.75. Whereas more than 17, 18 year, we keep 0.5 toward the myopic side. 18 year because that is adult. So thank